Good afternoon. It's good to see everyone. Some of you, it's good to see you again. We had the opportunity earlier today to have our Community Voices workshop, and it was really meaningful and a wonderful opportunity to really get in touch with the work that we're doing and why it's so critical. And so thank you all for, especially if you're doing it times two, thank you so much for coming back and participating. And I just want to say today is a really important day as we look toward our recommendations, and I look forward to that conversation and to hear what you what you have to say. So, and Claudio will be joining us in a little bit. This is just a crazy time of year with sessions, so many overlapping schedules, but good to see you all. Senator Marr?
Hi, also welcome. It was great to see people this morning. I'm sorry I wasn't able to stay the whole time, but the report that I've heard is that it was really productive and worthwhile. So I look forward to hearing more. Thank you.
Thank you. And good afternoon, everybody. As it was said, we do have quite a bit of things on the agenda today. Some of it is going to be technical, so please, be patient with us as we do need to take roll call. It is a voting meeting, and we need to ensure that we have a quorum. But first, before we get started, we need to vote for the approval of the January TCB meeting minutes.
So moved.
Can I get a second?
Second?
Mickey, all those in favor? Aye. Okay, any opposed? Abstentions? Okay, we're good. Thank you. Okay, I actually am going, as you heard about this morning, just very briefly, we had a very productive day. It was a full house, so it was very exciting to see so many people there. And I am going to give the floor to our facilitator from this morning who did just an amazing job, and our partners in this work, Health Equity Solution, Tyler Tucker.
Hey, good afternoon, everyone. And for folks who I just spent 2.5 hours with, it's lovely to see you all again. So real quick for folks who don't know who we are at Health Equity Solutions, we're a nonprofit here in Hartford, Connecticut that focuses on statewide advocacy, where our vision is for every Connecticut resident to obtain their optimal health, regardless of race, ethnicity, or socioeconomic status. And we do that by advancing health equity through anti-racist policies and practices. And I've had the real joy and opportunity to partner particularly with TCB, as well as the Community Voices Work Group and the Tau Youth Justice Initiative, to have really the honor of facilitating this space. And I really enjoyed today and wanted to give folks who didn't have the opportunity, but wanted to come or were not part of it today, to share a little bit about our framework and how we started this, and a really quick, wide view of what we've done so far and kind of what that looks like. So, as a reminder, our work here with TCB is really looking at transformative community engagement, which centers on the understanding of sharing power, trust, transparency, and mutual accountability as a long-term goal. And really what it does is ensure that communities can safely and meaningfully participate, influence priorities, and drive long-lasting change. So that's kind of our overarching work that we're focused on, particularly with the understanding that the Community Voices Work Group is meant to be a consistent partner in what TCB is doing. And really understanding how we begin to share power through multiple levels and different examples. And so before the summit, some of you might remember I ran some focus groups online to really get an understanding of kind of what's going on, what are the current knowledge and skills in the landscape around equitable community engagement, and clarify some really short-term goals around what is our hope for the summit, and do a little bit of short-level transformative community engagement work with the whole TCB, and lead a really robust prep discussion with the CVW work group, who was newly formed, to really identify what they hoped to see from parts of the summit. So for many folks who were here in the beginning, we were going to have a full day summit. And if you were just at the facilitation, we talked a lot about pivoting. So our facilitation got split in half. So I spent the first summit with just CVW members and community members, where we really built a foundation for authentic community voice in TCB. So understanding what that means through the lens of power sharing and consent and story building. We developed deeper relationships with CVW, the organizations, and community members, with really an integration for community, particularly because this group is new. So we were really building on what it means to work together, how we see CVW as part of this work, how community members fit into this work, and kind of what that begins to look like. And then we also shared a little bit of understanding around how we hold diverse expertise. And so just for folks landing, that was in October, as we spent some half day with the wonderful CVW group and community members. And so as you can imagine now today, we had the opportunity to share the space with all sorts of roles and members, including communities, community members, CVW, our legislators, our providers, our state agency representatives. And today was really focused on a couple things. We talked about pivoting and what it looks like to do this work as a system level work, and how we continue to operate and understand success. How are we seeing it? How are we moving the work forward? We also did a lot of partnership and community building. So it was one of the first times that folks were really integrated into a roundtable space. So we did a lot of understanding of shared community location, understanding how our values and strengths come holistically. So we did a lot of looking at, the value and strength of each lens and what the balance of doing this work together means and how we see each other in the center of our why, right? So really connecting why we are all here, why the work matters, and particularly as we're coming up to a really exciting day like voting, is really centering the why for everyone here and what it means to be in strong partnership together to move transformative work forward. And we began to think and uncover a little bit around indicators of success. So beyond just the wonderful work that you all do, looking at just QI is also thinking about, the smaller moments. How are we seeing success and how are we knowing that it's moving us in that direction of transformative change? And so with that, I'm going to pass it back to y'all.
Yeah, and I do want to thank again Health Equity Solutions. They've been just wonderful in this process, just great thought partners and providing the technical support needed to the Community Voices Work Group. And I look forward to continuing our partnership with them and continuing this work with this committee because as we all know, the individuals with lived experience is what brings, this to life in the sense of what's working, what's not working, and we need them at the table. So when there's the conversations about sharing of power, that's just so critical. So again, look forward to continuing this work with Health Equity Solution and with the parents and the community members and with you all. So thank you. With that being said, I'm going to give the floor to Emily. We do have some administrative updates. I do want to, it may be a little choppy today because I know that there are other members that are also saying we're on our way and they want to be part of the vote. So there is some administrative update that we need to do in the sense of doing a roll call to ensure, one, that we have quorum, two, that the individuals that are going to be voting are either the appointed individual or the designee. We need to clarify. You only get one vote. So if the two individuals or three individuals are here, it's only one representative of that, of either the appointed or the designee. And so when we call roll call, please let us know who will be voting a representative.
Good afternoon, everyone. So I'm going to start off with some brief administrative updates before we go into the voting. So on the screen, I know it's cut off a little bit at the top, is our draft annual agenda. On this slide and the next, we are working on finalizing this and should have a final version for you all in next meeting, so March 4th. If anyone has any specific recommendations, as you see, we do have some draft focus areas. If anyone has any comments or suggestions on presenters or things you would like to see presented on, please let me know. And I'm happy to set up a meeting to discuss that further.
And one thing that Emily and I are striving to do this year with the TCB is that as you look at the draft annual agenda, mind you, it could change. So for example, a specific topic may change from month to month. This is sort of our roadmap. This is our administrative tool. So please know again that it is a draft. But what we're trying to do this year is that we're trying to create themes where, if we're talking about a specific topic or an area of learning, sometimes 1 month is not enough, like one meeting is not enough. So we may have to have like 2 or 3 meetings focused on that particular topic of discussion so that we can really digest that information and so forth. So that's one thing that you'll see. The other thing that you'll see, so you'll see a specific topic maybe month to month. You will also see that we've added some workshops because sometimes we need more than that 90 minutes or 2 hours. And so we may do a workshop in the morning of TCB, and then move into our regularly programmed meeting, just like we did today. So for example, we're also trying to acknowledge, that May is Mental Health Awareness Month, and you are all children's behavioral health. And so that is something that we may want to bring in some panelists and some content experts around that area for that discussion. There's also, I believe it's February
February, the last week of February is a eating disorder awareness. And so we're looking to see how can we make sure to continue those conversations around educating and informing the committee so that we feel like we have enough information to move forward with some of this work. So those are some of the things that you'll see there. Again, this is very much draft, but it's a roadmap that we use to help us move each month and plan for. And the last thing I would say about this too is that if you see your entity, your state agency identified, this is also sort of giving you a heads up like, hey, we may be reaching out to, Department of Children and Families or DDS or, DSS on such and such month. And, we'll work with you to plan ahead of that particular month so that everybody feels ready for that, what the ask is for that month. Okay.
Thank you. So again, we will provide a finalized version next month at our March meeting. So some upcoming work group meeting dates. We have a lot of meetings next month for the work groups. System infrastructure will meet February 17th from 3 to 4:30 on Zoom. Services will meet February 18th from 2 to 3:30 on Zoom. School-based met already this month on the first Monday of the month. So our next meeting is March 2nd from 3 to 4 on Zoom. And then prevention will meet next Thursday, February 19th from 3 to 4:30 on Zoom. So I'm going to provide some updates. There are a lot of TCB studies that we have been working on in subgroups of the different work groups. So you'll see listed below in the school-based work group, we have 3 different subgroups that have either formed or we're working on forming, including the school-based health center study, the school billing recommendation, and behavioral health concerns in special education students. For services, we have subgroups of the crisis continuum review and marketing and communications plan for the crisis continuum. We have the UCC private insurance review, the ICAP study, which we'll be hearing a little more on later today, and the Connecticut Behavioral Health Provider Survey that we will also be hearing more about later today. And then the system infrastructure work group, we will touch upon the cross-agency data work group later in this meeting. But that will be a subgroup of the system infrastructure work group that will focus on the Connecticut Data Infrastructure Report that was presented this past October. So just some updates on these studies to kind of show where we are at. So the school-based health center study, again, this is a subgroup of the school-based work group. We have been meeting with DPH regarding this, and last week, the Talue Justice Institute, along with the school-based work group chairs and DPH, met with the National School-Based Health Alliance to discuss best practices and model examples. We are hoping to have a finalized scope of work by March 2026. The next subgroup out of the school-based work group is the school-based billing review. We had met a few weeks ago, or last week, and we discussed the scope of this effort and also obtained clarity on different Medicaid billing documents that we have found in the process of starting this subgroup. And for next steps, the group is to review the materials shared from the meeting last week and really develop and build out our work plan for next steps. And our goal is to either meet in late February or early March. And lastly, for the school-based work group, we have the behavioral health special education subgroup. We had met, I believe, at the beginning of January. We are currently awaiting just additional information and resources related to this specific legislation. And once that's received, the group will begin developing a project plan and moving forward with this work. So the next one, and this is a subgroup out of the services work group, is the UCC private insurance review. We had met in December as a group to discuss the intent of the legislation, current updates, and barriers to private insurance billing for UCCs. We are going to meet with the behavioral health advocate, I believe, later this week to kind of talk about next steps regarding this. And I know discussed in that meeting was we were really waiting for claims data to come in regarding the UCCs to get that data to discuss further with the subgroup. So the next one is the crisis continuum review. And this is a big one because it's kind of split in two. So the first half you'll see in the draft intent and also the scope of the project. We are looking at rates of utilization, but also looking at data. So in December, we had the crisis continuum data panel. A lot of that data is what we're looking at to build this report. In the meantime, as we're waiting for the fall of 2025 data, it came to our attention that we needed to focus on the utilization of these services immediately. So we've also developed a subgroup with the help of Howard, where we're focusing specifically on a marketing and communications plan for the crisis continuum in Connecticut. So we've been meeting in person almost monthly for the past 4 months. And we actually met last Friday where we reviewed the project plan and budget. And the Talia Justice Institute will be working with both United Way and Daydream Communications as they have been contracted to lead the marketing and communication efforts. And I can now pass it to Victoria.
While Victoria's getting set up, can Representative Exum and I would like to ask a favor. Next time, next meeting, could you all come closer so that we don't feel so left out here? I mean, not only do we feel like isolated, but on the screen, it doesn't look like anyone's here except us, which is kind of crazy because you're all so committed to being here. So anyway, that's just our request. Thank you so much. So sorry, Victoria.
Thank you. I'm Victoria Staub. I am the clinical director of the ICAPS network. And I'm here to talk about an ICAPS study that was really move closer. Sorry, I'm soft-spoken. TCB driven and supported and couldn't have happened without the TCB. So really involving lots of different institutions working together and collaborating. And so we're calling it now the ICAPS TTE. That's our name for it, which stands for Target Trial Emulation. And really, it's kind of trying to simulate a randomized control trial using retrospective data and using just administrative data. So we're not hopefully going to be kind of intruding in people's lives and needing lots of consents and things like that. We know that our ICAPS kids have had a recent psychiatric crisis, but we also know from studying them for quite a while that they have multi-system involvement generally. And so part of the study, we're hoping to kind of look at whether ICAPS has an impact across systems at reducing the intensity of utilization. We're also hoping to look at our intensity and duration and hopefully make some recommendations about ICAPS length of service, intensity that's recommended. And we have a couple other secondary analyses that we hope to do that would all aim to support policy making and the sustainability of ICAPS and hopefully potentially scaling up ICAPS.
And thank you, Victoria. And if I may ask a question, a favor of you, if you could just high level remind people what ICAPS is.
Oh, absolutely.
Because everyone doesn't necessarily.
I'm so in ICAPS land. So ICAPS stands for Intensive In-Home Child and Adolescent Psychiatric Services. It's offered across the state of Connecticut to children who've had a recent psychiatric emergency. We get referrals from all over, so from DCF, from juvenile justice, from schools, from psychiatric hospitals. And we serve on average right now in the post-COVID around 1,200 kids per year.
And it's an in-home and it right now the duration is
6 months.
6 months, 6
Yep,
months.
intensive. And so it's 3 sessions a week, about 4 hours, 4 to 6 hours.
Thank you.
Any other questions? Victoria, just one quick question also for high order level is in this for the study, the TTI study? TTE study. What is the sort of projected timeline?
Absolutely. So we have to build a database to stream all of this data from different places into. That timeline's about 7 months once we get our contract up. And during that time, we're really hoping to do all of our data use agreements and get our IRB through. And then in year 2, really doing a lot of the analyses. We're hoping that we can do a 2-year plan with a possible 3rd-year extension.
Victoria, why does ICAPS have to go through this kind of testing? Is that an unusual thing for a level of care in the state? I just was curious about it.
So in order to receive more funding from the Department of Children and Families, we need to be qualified as an evidence-based treatment. And that funding really supports our training and quality assurance and quality improvement. As of right now, we're not federally evidence-based. We have quality assurance and quality improvement data that we submit on an actually quarterly basis. But this study will meet clearinghouse standards for evidence base.
Commissioner, I'm sorry if you don't mind. So then that means that on a state level, you can get reimbursed more? Thanks.
Yeah, that's correct. Yes, exactly. Yep. Thank you.
I'm hoping I can ask a question. Will you keep data on how many people with intellectual disabilities that is affected for, and maybe their treatment model may have to look different than others?
Absolutely. So we already know that we see quite a few individuals with intellectual and developmental disabilities. The program's already very much tailored to be kind of multiple comorbidities. Because most of the kids we see have more than one diagnosis. The average is actually 3. So I think it's a good point. I think I would be interested in using funding to really kind of hone in on working more and working better with families with intellectual disabilities.
And then can DDS make a referral to ICAPS?
Can who?
Could my agency make a referral for someone to ICAPS?
If they have recent psychiatric acuity, yes.
Oh, thank you.
We don't, generally it's moderate to mild. So generally it's not profound intellectual disability. That's
Any other questions around the ICAP study?
I have a question also. So in doing the TTE,
Mhm.
will that also be looking at the feasibility around, I think you did, I think I'm about to answer my question, but the feasibility around something shorter or a different type of model, understanding 6 months for some people is a long time. For some people, you may not need it to be as intense. So I'm just wondering if
Yes, and that's something, Rep. Exon, that you've brought up many times, and I know we've talked about, and I absolutely agree with. From the network's perspective, most of these agencies have wait lists that are already 2 to 3 months long for the highest acute kids that want the longer service. So I think from that perspective, we both want to study what having a longer duration of ICAPS means for outcomes. We also want to study what having a shorter duration could do, and in there look at intensity as well. So
Thank you.
Mhm.
And that was one of the reasons too, looking at that wait list, seeing ways to address some.
maybe the shorter, yes.
Right.
I think I think kind of from an agency perspective, although I don't run in ICAPS, I've talked to many people who do. It gets complicated when you have certain teams carrying cases. It's much easier when you standardize, I think, because then you can manage the influx of referrals as they come. What we found out over the summer as we studied the wait list is many more kids are referred to ICAPS than receive ICAPS as well, in part due to that wait list.
Thank you.
Christina?
Yeah, I think the sort of flip side, and I think you mentioned this, Victoria, is just what the feasibility is for longer periods of ICAPS, because one of the things that we see is children who really benefit and families who really benefit from the ICAPS service, but because it's time limited, it ends, the family has to find a new individual therapist for the child, maybe a family therapist. And then because there are challenges, they end up back in the hospital being re-referred or things of that nature. And so I do think we should look at the feasibility of some folks who actually stay in ICAPS longer to try to prevent, what we sometimes call the hospital merry-go-round, the emergency merry-go-round, right? You get a service, you're doing well, the service ends, and then the challenges are still there. So I just want to sort of put that on the table as well.
I think that's a great suggestion. I think it's looking at all of that, shorter, this way it is the standard 6
Repeater.
months, and then a little bit longer, because it recognizes the differences in the different children and the situation in which they present. I think that's a really good suggestion.
Alice?
I just, that's a really important idea and interesting in the infrastructure conversation. Connecticut's looking at the system of care from New Jersey. And the system of care in New Jersey, that was the one thing they found actually after they implemented, that they didn't have that in-home capacity. And that's what they made the change in. So I think once we start as a larger group hearing about that, we can learn from what they learned. But I think that we've talked a lot about that as being a critical add in there.
And to Christina's point, I think in the time range that we're looking at retrospectively, I imagine we'll see multiple kids who've repeated multiple times just in that 2 years. So thinking through what those kids could have benefited from as well.
Mickey?
Yeah, thanks. I think that one of the things that we have to be thinking about for any of these kind of higher level, more intensive services, including out-of-home services, is kind of, do families do or children do really well in program, but what's the sustainability of the gains, right? So we want to make sure that there's sustainability, that whatever's learned and gained, that 3 months out, 6 months out, a year out, that family and child are a lot healthier.
So we're planning to look at a year before and a year after.
Any other questions? Oh, Michael?
I gotta have that, right? Okay. If this group votes on one of the items, which is about the PRTFs, will there be any intersection or opportunity for the project you're talking about to be able to address those kids with ID and developmental disabilities in the questions that you're asking? Because a lot of those kids have had ICAPS at one point, and then they end up in continuing to have great difficulties. And so coming back to what Tammy was talking about, finding a way to understand what those kids went through and their families went through, to be able to inform what you're doing. If that's possible, it might be a point of intersection to get even more information that supports your inquiry.
We know from having studied ICAPS for quite a while that a big subset of the kids have chronic high-level issues. And so it's not just the kids with ID, but they're certainly like a subset. And the way generally we conceptualize it is that ICAPS would be a booster during periods of developmental distress. But what we generally find is there's no kind of step down, or there's nowhere to to help support during the intensive in-home. And so then PRTF is where you end up going when it gets to that really high acuity point. I don't know whether, I think we can make recommendations. We're hoping to look at kind of diagnostic clusters and outcomes based on different, maybe neurodivergence, maybe developmental disabilities, et cetera. But overall, I think our hypothesis is that the program's able to bring down the level of service use for all of these different types of kids. And the question is, it's a very expensive program too, and it's intensive. And so What would it mean to make these changes? At least the study we will be able to kind of make some informed recommendations and then I'll come back and consider. Because some of the changes that are being requested are really huge, systemic, and would change the way agencies are running the model as is.
I just wanted to address the quick we need to use our full terms because we're all at different places. So the PRTF is Psychiatric Residential Treatment Facility.
Mhm.
Just wanted to put that out there. Alice?
I just, this is probably very obvious to folks, but I just really want to talk about the behavioral health system that you're hearing is the continuum of care that folks need, right? And, pediatric care is like that. I have a 26-year-old who had a sore throat and her pediatrician saw her, right? And he saw her when she was 7. In behavioral health, it's episodic, right? And every time, and it's really that way because of the billing structure. You have to close out and we collect our data, the PI data at the end of the treatment area. And it's really based on a bureaucratic system, not a humanistic system, right? And it would be great if we could have a behavioral health or a social driver of health or some sort of system that actually covered you no matter where your age and, for continuum. That would be really what's there. And I think we should look at the system and why it's that way. Thank you.
Thank you for that, because that is actually something that we've all talked about. As you move across from all the different alphabets and the different diagnoses and the different forms of service provision, this is the reason for this. This is to create the pathway for people to not have to negotiate so many different organizations and processes and ways of receiving treatment. So I know it is definitely our holy grail, but it's at top of mind all the time. So thank you for bringing it up again.
Hey, we have anybody else? Oh, Sarah.
Yeah, just a quick question. I hope you may have said it and I missed it. So sorry, just tell me. When you're doing the longitudinal aspect of the study year before, year after, are you going to be looking at, are you going to be able to look at what are the characteristics or other indicators that make a family more or less likely to benefit in a sustained fashion or to either benefit during the episode of care or benefit in a sustained fashion from ICAPS? And then sort of related, in the year following or during the episode of care and in the year following, what were the others, will you be able to discern at all whether there was other services provided to the child that may have, or family that may have helped make, or not, that helped make ICAPS more or less successful in the long term, right? Because, I hear all the time, well, I had that and it didn't help me, right? But we know that the service doesn't mean, this, but like the service doesn't exist in a vacuum, right? And as you
No.
said, right, these are multi-system involved families, lots of needs. And so as we want to move to a more holistic way, a family-centered way of delivering care in which ICAPS could be a critical piece, right? Maybe is there an opportunity within your study to think about what is the data telling us about the other pieces that are really important to maximizing benefit over a period of time for the family?
So, of course, that's a huge question, Sarah. One of the first things that came to mind initially when you were talking that we hope to look at is we hope to look at kind of zip code and like community and neighborhood and social determinants of health in that way. Because we know we have ICAPS all over the state and in very different areas, and each kind of have their own subset of issues. Another response I have to you is that we're asking to look at the whole continuum, really, and we hope to do kind of a final cost analysis as well, because another one of our hypotheses is that ICAPS, in fact, because it's longer term treatment and not crisis response, saves money in the long run, especially for our highest acuity kids. So we'll be accessing like outpatient, all behavioral health claims data and looking at that for each ICAPS kid and whomever we match that did not receive ICAPS. Did that answer your question? Sort of?
It does, just raises more questions, but I don't want to hog the microphone.
So, but as you know, the more questions, always please send it over to us. We are in constant communication with Victoria, another great partner in this work. And so we look forward to continuing on this project and continuing to bring you all updates as the work progresses. And so I know that this work lives in the services work group, correct? In the services work group, so we will be processing that through there as well.
Yeah, just
Okay.
my deepest gratitude. Thank you so much for your help. This wouldn't have taken off without your help. So.
Thank you. And now we're going to move over. We're shifting the agenda as we're pivoting, like we learned this morning, just pivoting because we don't want to lose some of our voters as they also have conflicts with other things. So we're going to move over to the recommendations before going to Jill from Innovation Institute. So we first need to do a roll call. And so I'm going to give the floor to Emily to go over some protocols and the roll call for who's here. And then we'll do a little bit of level setting on each of the recommendations.
Thank you. So starting, we do need a quorum of TCB members present, which is a total of 25 members. So I will be calling out the name of the original appointment and then the designee. If the original appointment is here, that is the person who would indicate their vote. So if that person is not here, I will then call the designee's name. Are there any questions before I begin the vote? And if you are on Zoom, if you could please just come off mute if I call your name
And off screen.
and off screen. Okay. Claudio Gualteri,
Here.
Senator Marr,
Here.
Representative Exum,
Here.
Senator Anwar, Jeff Vanderploeg,
Here.
Representative McCarthy Vahey, Senator Somers,
Designee Jeannie Milstein here.
Representative Clarice Detria, Jessica D. Negri, Senator Lesser, Representative Gilchrist, Senator Perillo, Michael Powers,
Here.
Representative Case, Michelle Anderson, Jody Bishop Pullen,
Here.
Representative Paris, Mickey Kramer,
Here.
Representative Dufresne, Senator Austin, Representative Walker,
Present.
Allison Van Eaton, Javid Sukra,
Yes, here.
Tammy Freeberg, Alice Forrester,
Here.
Representative Belton, Sarah Egan,
Here.
Sherry Shapiro,
Here.
Jan Ponson, Melissa Santos,
Here.
Ashley Hampton, Giselle Acevedo, Edith Boyle,
Here.
Commissioner Hamilton,
Here.
Commissioner Quiros, Michael Morvisek,
Present, but Commissioner Kuros will be on for DOC.
Commissioner Chef,
I'm his designee, I believe.
Interim Commissioner Trueworthy,
Lorna Thomas Farquharson is the designee.
Commissioner Russell Tucker, Deputy Commissioner Cynthia Sohn Moyano, Commissioner Hirschman,
Gerard O'Sullivan, designee, here.
thank you. Kimberly Carnata,
Here. Designee per Commissioner Navarrete.
Commissioner Giuthani,
Deputy Commissioner Lisa Morrissey, designee for Commissioner Giuttani, present.
thank you. Commissioner Barton Reeves,
Designee Von Polato, present.
thank you. Commissioner Porter, Boyd Jackson, Christina Gio,
Here.
Sean King, Howard Savronsky,
Here.
Gary Roberge,
Captain Foley Guide for Gary Roberge, designee.
thank you. Melvette Hill,
Here.
Michelle Scott,
Here.
and Betty Ann McDonald. We have reached quorum with 32 members present, so we can go into the legislative and policy recommendations.
Okay, thank you. And just a little bit of a recap from the last meeting of where we presented the legislative concepts. Typically, the process is that we bring forward recommendations from work groups and or other commissions, task force, and so forth that are centered around children's behavioral health. In January, we introduced 3 concept recommendations. One of them was being the data sharing work group as a policy recommendation, not necessarily being brought forward as a legislative recommendation, which would be folded into the work plan of the TCB. The second, you heard a presentation from regarding disordered eating behavior. And there is 2 recommendations coming forward from that. And then a third recommendation at that time was around the UCC Urgent Crisis Care PIC recommendation data, and it was basically determined that that was not going to move forward for this legislative consideration, but that, or policy recommendation, but that there would be work with the state agencies around, ongoing sustainability of that. So a recommendation that did come to the TCB, again, as the TCB is centered around children's behavioral health, is the psychiatric residential inpatient treatment facilities, PRTFs, as we were talking about earlier. In your package, you should have a recommendations justification document. And in that justification document, it lists out the 3 recommendations plus any background, very brief. We don't want to do a 20, 30-page document. It's just very brief snapshot. And for that particular recommendation of the PRTF, that is the last page, page 5 in your package, as that it was a particular public act that was passed, Public Act 2589, Section 5, which put together a group that looked at complex case work group. And I know we do have some representation here from that particular work group that can provide any other information around this PRTF recommendation. Those would be the 3 recommendations. Actually, it's really 2 recommendations. Disordered eating has 2 parts to it, but the data sharing work group recommendation is not coming in for necessarily any legislative. It's just part of the work plan. So really today we're voting on 2 sets of recommendations. Any questions or comments on any of these, or anything else you'd like to learn further about those 2 recommendations? We do have representation from both of those recommendations that we'll be voting on today here to answer any other questions or give some more background. Claudio?
Just to say, very proud of the fact that this group, since we started, never lost sight of the fact that sometimes there's complex co-occurring conditions with both mental health and either autism or IDD. And I think that that's always been true to the North Star that we've all had. And I appreciate that last time we did that incredible work to increase coverage for autism applied behavioral services up to 26, not losing sight of that population. And we're carrying forward that theme again this year with the good work that Tara and the OPM team across all the different agencies worked on, recommendations to build out the capacity we need, and recognizing too many children are falling through the cracks, and what can we do to intentionally plan for and develop that needed capacity. I think it's going to provide throughput across our system, including some much needed relief in the hospitals. I think it's going to be great from the perspective of trying to look at when agencies have to work across different systems, and that we look at it from the consumer and the patient perspective, not from a silos artificially created by state government, because that doesn't always work. And I really want to appreciate the fact that it takes everyone suspending a little bit of their comfort level. I know Commissioner Hamilton was just really working with us for the past 2 years once we identified a problem, and Tammy Venegay from DDS, just staying at the table and suspending judgment until we could sort of get comfortable with a consensus solution. So definitely thank Tara for her work on that, and the agencies that were part of it. Human Services Committee for making us focus on that work. Sometimes passing a bill and putting people at the table and focus intentionally on a solution makes so much of a difference. The last thing I'll say is I also am very proud of the fact that people are coming to TCB as a filtering mechanism to lift up the most promising ideas. So when we had our great friends from the legislature here presenting on the eating disorder and seeing the connection of their work into the children's behavioral health space, I so much appreciate that. And I think we're doing what we were charged to do, be the convener of things in a cross-cutting way for children's behavioral health. So could not be prouder of the work on the heels of just passing a bill a few months ago. So we're really on great track. Thank you.
I'd also like to say something. And I think, Claudia, I think you summed it up really, really well. But when I look at what we're doing today, I am very proud of the work we've done. I know it feels slow. This whole thing moves slowly. We know that because we're trying to do something that is from the ground up and really listening. And this afternoon, we spent time, this morning rather, with our parents, right? The parent voice. And many of you know this, and pardon me if you were there earlier today, but I think it's so important. And when I look at the recommendation that is coming forth around the eating disorders, I just remind you that's where this started, an eating disorder and a young man who could not get what he needed in his community, and someone who couldn't get what he needed later outside of his community, throughout the state, and eventually in another place. And the route to that was not linear. It was a very difficult route. And along that way, that pathway, we found one thing after the next where you couldn't get the support you needed, where we had phone calls, we can't help you here. That's too difficult for us. We have 2 places. We don't take boys. It's this distance. What type of insurance do you have? Oh, you don't have. It was so incredibly complicated. And it lands at the middle of this. It's the voice of a parent. And later you may have a role that allows you to make some of these changes and these recommendations. Eating disorders are the #1 killer of behavioral health disorders. I was so surprised when I found that. But when you have a child who's in the thick of it, you see it. And to have these recommendations now, it took longer than I wanted to in a way because it was at the center of why we wrote this. It was the reason that the speaker asked if I wanted to be a part of this. But that bill that we did in 2022 tells the story of what can happen in all the gaps. I love that we're now having a place where we come to together and we're trying to address those gaps because those gaps are children. I know ICAPS well because I got to experience ICAPS in a very different way. The 2 people who came in and came forward who worked with us, who were great, 2 master level social workers in the home helping us stabilize. But we got a grant. We got lucky. I didn't even know what ICAPS was. And we weren't involved in multi-system anything. We were outliers over and over again. And so when we look at these recommendations, they're really real people's lives. And we found that out. We know that with the community voices work group. And I wanted them to know that we weren't just making decisions for them as legislators or as state agency people or people from policy, but that they're actual parent voices embedded in this work and is foundational. So thank you so much for this. I hope we can continue to bring forth, and I'm very excited about the changes we're making. While it might take time, it's changing and saving lives. And look at the UCCs and what we're doing around the autism piece and so many others. And so I thank you for these recommendations and hope you will support them.
So going back to the theme of time and the fact that it takes so much time, when I get frustrated, I look at JJPOC, which has been in place now for over 10 years. And I look at what the origins of that work, Juvenile Justice and Planning and Oversight Committee. I look at the origins of that work and where Connecticut was with juveniles and detention and the ways that the kids were bearing the brunt rather than being lifted up and helped, and where they are now. It has come so far. So when I get frustrated that this takes so long, I appreciate you all showing up, because it is only by walking through it together and sometimes making mistakes, sometimes having a bill that should have passed earlier, not passing till later. You know, there are a lot of those things that happen along the way, but it's so important that you continue to show up and that you lend your voices and your thought process and help move us along, because I do have faith we are going to get there. So thank you.
Okay. Any questions before we call a vote, or any comments? Oh, go. Oh.
I just want to clarify, this is just the vote on the first recommendation?
So what we're going to vote on, so recommendation 1 that's listed right now on the cross-agency data sharing work group, we're not necessarily going to vote on that because that's just, it's not a legislative, it's just part of the work plan of the TCB, and it's going to be living in the infrastructure work group, and we will work in partnership with those state agencies and other data representatives to take the Innovations Institute report to help to build that system. And at a point when we do need legislation based off of whatever they have created, or, you know, either determine what's viable and not viable, if they determine that we need legislation to make something happen, then we'll be bringing that back. But so for today, we will be voting on the recommendation that is the disordered eating recommendation plus the PRTF.
Okay. I do want to make a comment with regard to the PRTF, so I'm not sure if I should.
Oh,
is it now the
yeah, this is
appropriate
the
time,
time now. Yeah, this is
Okay.
the time now. Chris.
So I do want to lend OCA's support to that recommendation for the PRTF for youth 14 to 21 for children who have intellectual disability and autism. So our office, one of the things that we do is we receive concerns and complaints, and we get them from everywhere. We get them from parents, we get them from hospitals, we get them from community providers. And one of the things we see quite often, and that Liz Sittler, our assistant child advocate, works on every day, is children who are stuck somewhere, many of whom are stuck in the emergency room or in the hospital and in need of a PRTF. And many who wait a long time. Within that group, a very long time, within that group, there is a subset that we see that waits an even longer time. And those are children who have intellectual disability and autism. And what we see often is they're either denied the PRTF level of care, even though it's recommended, because the co-occurring intellectual disability and autism, or there's not even a referral because everybody knows that this child's not going to get accepted. And if I could just ask your indulgence, I wanted to share two cases with you. We had a call on a girl who was 13 years old. She was in the emergency room. She had a special education therapeutic day school who was working with her. She was diagnosed with intellectual disability, autism, and significant mental health needs. She had severe sensitivity, sensory sensitivity, and significant aggressive behaviors. In fact, her behaviors had become so aggressive, and really in response to that sensory sensitivity, that the ABA providers, applied behavioral analysis, which is sort of a particular treatment intervention for people on the autism spectrum, would not come into the home anymore. It was just, they deemed it not safe. And so she was in the emergency room. She needed a higher level of care. The therapeutic day school said maybe we could meet her needs if she was here residentially, but the school wouldn't agree to that. We got involved. We advocated for a higher level of care. PRTF wasn't even on the table because they knew she would not be accepted. I believe she was also nonverbal, and which made it even more challenging. We ended up connecting that family, frankly, with a pro bono attorney, because our assessment was the fastest way to get that child what she needed was through the school district in a residential educational placement. But if a PRTF had been available, that might have been an appropriate place for her, and then she may have moved back to her community and lived with her mom and been able to be served by that therapeutic day school. And what I want to add is, even when the school agreed to a residential treatment program, she sat in the emergency room for another 4 months, not in the hospital, in the emergency room for 4 months, waiting for that placement to become available. And that's, I think, the cost of not having PRTFs. We saw a similar thing with an 18-year-old who was on the autism spectrum, had intellectual disability, had significant behaviors. He was actually had been in our state's inpatient hospital, Solnit, was discharged to a group home, and then had a very significant behavior that resulted in him going to the emergency room. And again, he was denied access to the PRTF because of the combination of disabilities. They could not meet his needs. And he sat in the emergency room for many, many months, and eventually the hospital agreed to do what was called a social admission. So he was sort of inpatient, even though he didn't technically meet the criteria for inpatient, but they couldn't send him to a PRTF. And it took, he was in the hospital for the total with the emergency room and the social admission for 15 months before DDS was able to secure a type of placement for him. Again, potentially someone that could benefit from a PRTF. And so we really feel strongly that this is absolutely necessary. I do want to say the first story, that child's 13. So something to think about is what the age range needs to be, because we are seeing more and more young children with very, very high levels of need. But I would encourage everybody to support this. We absolutely need it. And sort of from a disability rights perspective, it is absolutely inappropriate and discriminatory for children on the autism spectrum and children who have intellectual disability to not have access to a level of care, which is really what we have right now. So thank you.
Sarah?
I just want to say number one, thank you for sharing that story. I mean, that any child would sit for 4 months in an emergency department is just staggering information, right? But I think your comment also raises something that a theme, and the recommendation, right, raises something that is very important for us to think about from a policy standpoint, right? Which is the intersection of educational choices and spending and lack of services on the behavioral health side, right? So I'm going to lift up that OCA and Disability Rights Connecticut, and my colleague Tom Kosker is here too today, released a report yesterday about the placement of hundreds of Connecticut students into out-of-state residential programs through their LEAs, through their school districts, to the tune of millions and millions of dollars, and with over 17 of those programs either unlicensed or unaccredited in the receiving state, right? With all the problems that go with that. And I just think there's a link between, right? Because who's getting moved out of state into those facilities are the same children we talk about here, right? Whose parents become desperate for solutions because they can't find them close to home, right? And so when we think about spending, right, the money is getting spent. It just gets spent on the education side rather than the behavioral health side in ways that we have a lot less control over than the continuum of care, right? I mean, right now, Connecticut spends probably $600-700 million a year on outplacement, including residential education programs. Some of those programs are terrific, right? But like the intersection between that investment and unmet needs of these children in our behavioral health system are profound and really important to think about, you know, and look at that analysis. The second comment I'd have about the recommendation is that while I agree that it will be important to ensure that every level of care, insurance funded and Medicaid funded in our continuum of care, is accessible to children with intellectual and neurodevelopmental disabilities, including, you know, of an acute care setting, the model of how that care is delivered, I think, always needs to be examined for effectiveness, but definitely will look different for this population of children. And I don't know if there's some language in the recommendation that could speak to that the model itself and development of an RFP, but the model that goes into the RFP should be done very thoughtfully in consultation with people who have a lot of lived and other expertise around what an acute level of care should look like for these children and their families.
We have Jeff and then Dr. Powers.
Thanks. Yeah, I agree with everything that Christina and Sarah both had to say. I just want to add a couple of additional observations about the language of the recommendation. I think that it's likely that, and I agree with everything that was just said, that the PRTF level of care is really necessary for individuals with IDD. And I think it's important to keep that in the language of the recommendation, but I also, just to underscore some of what the two prior speakers were saying, there are also other levels of care that are likely appropriate to ensure are accessible for individuals with IDD. And so PRTF is one important service for that population, but I wonder if there might also be some language that could be added to suggest that we look at the accessibility to other levels of care outside of PRTF for individuals with IDD. And the second observation I wanted to make was just around some of the language that clearly is kind of looking at the ensuring that there's an ability to bill Medicaid for this PRTF service. But I wanted to ask whether that sort of supposed that the level of care that's being proposed, the RFP that's being proposed for the 10-bed facility, was aiming to be only accessible to those who are enrolled in Medicaid, or whether the idea was that this level of care could be open to those who are commercially insured as well. And of course, as we all know, individuals with IDD may be enrolled in Medicaid, but they may not be as well. They may be commercially insured. And so to think about access for non-Medicaid enrolled individuals as well. Thank you.
Tara, did you want to or answer the question around the Medicaid piece?
I think that there is interest in it being non-Medicaid as well, and accepting private insurance. It was not the intent to state that this would be Medicaid only. And regarding the PRTF, there is, I believe there's still a comment in there on the last one, is that part of this is to examine if the PRTF would actually meet that level of need and level of care that we're looking for this population. We want to ensure that it's focused on getting behavioral health treatment for this population of kids. That's the primary focus. But heard from some stakeholders questioning if we had to commit to the PRTF model specifically. So wanted to make sure that we included that as we're looking at developing this further and making sure we continue to have those stakeholder conversations and gather more clinical expertise on what the best facility would look like.
Thank you. Dr. Powers, and then Mickey, and then we do need to move to a vote because I don't want to lose people. I want to keep us at a quorum.
I'll be quick. With respect to the eating disorders work group, is it anticipated that you folks will be including in some way those kids with autism where eating disorder problems, ARFID, avoidant restrictive eating difficulties might be included, because that represents between 60 and 75% of kids on the autism spectrum. Okay, they're mostly very young. Okay, but nonetheless, the restrictions for eating have social, behavioral, physical sequelae. So it's worth thinking about at least. The second comment I have is with respect to the PRTF situation. You may or may not be aware that DSS undertook between 2015 and 2020 2 projects where we produced fairly substantial reports on both the assessment, implementation, problem analysis, and community involvement using 2 of the PRTFs in the state. There's pretty substantial reports that were submitted to DSS for that. And the group who's working on that, should that go forward, might find that helpful, because the recommendations for moving forward, especially with sustainability and community involvement, without being in the PRTF, were, I think, very well designed based on the data that was collected.
Did you, TJ and Nova, did you?
Yes. So I can answer the comment on the eating disorders work group. So right now we don't have the full membership made out, but we will absolutely include membership from the autism community as we go forward and, look at where the group is going and our recommendations from there. So yeah, absolutely. Thank you so much for bringing that to our attention.
Mickey, and then we're moving to the vote.
Yeah, this is just a very minor technical thing, but when it lists the state agencies under the PRTF, the state agency involvement, the Department of Public Health actually has a very significant role in the investigation of concerns that they are, I don't know what the term is, but where DSS is the lead and they actually then delegate to the Department of Public Health. So it's nurses that go in, and nurses and clinical people that go in to examine conditions of care and treatment. And they are also the ones who will issue reports and set up kind of the expectations of the clinical environment. So I would strongly suggest that we include the Department of Public Health.
Tara?
I don't have an objection to that. They were not part of the work group initially, but I don't have an objection to that.
Okay. Right. Okay, so we're going to start with the eating disorder recommendation, and the language is in your packet. For those of you online, you should have received in Emily's email the packet of the recommendations. I don't want to read the whole thing, but the eating disordered recommendation is a two-part recommendation. We're going to just, if it's okay with the chairs, we'll vote one, as a set packet and not do two votes. Is that okay? Okay. All right. So this recommendation in sort of big picture establishes an eating disorder working group and holistic food education work group administered by CWCSEO. And it also asks that the commission submits a report back to the TCB as to the progress of how it is moving along. And then the second part to the report is that, or excuse me, the second part to the recommendation is that it incorporates, that's one question, is the eating disorder. That's one recommendation. And then the second recommendation of this set is incorporating a question on the disordered eating behaviors into the behavioral health section of the Connecticut School Health Survey. That is recommendation 1, and we're voting on those 2 subsections in one set, if that is an agreement.
So moved.
Okay, second? Okay, second. Okay, we have to do a roll call on this, so we'll call everybody.
Thank you. Claudio Galtieri,
Aye.
Senator Marr,
Senator Mar votes yes.
Representative Exum,
Yes.
Jeff Vanderplug,
On behalf of Senator Anwar, yes.
Representative McCarthy Vahey,
McCarthy Vahey votes yes.
Senator Somers,
Jeannie Milstein designee, yes.
Representative Clarence Dietra, Jessica D. Negri, Senator Lesser, Rep. Gilchrist, Michael Powers,
Yes.
Jody Bishop Pullen,
Yes.
Nikki Kramer,
Yes.
Senator Austin, Rep. Walker,
Yes.
Allison Van Eaton, and Javid Sukra, not sure if you're still on. Tammy Freeberg, Alice Forster,
Yes.
Sarah Egan,
Yes.
Representative Belton, Sherry Shapiro,
Yes.
Jan Ponson, Melissa Santos, Edith Boyle,
Yes.
Commissioner Hamilton,
Yes.
Commissioner Quiros,
Yes.
Tammy Venega,
Yes.
Lorna Thomas Farquharson,
Yes.
Gerard O'Sullivan,
Yes.
Kimberly Carnata,
Coranda, yes.
Deputy Commissioner Morrissey,
Yes.
Yvonne Paludo,
Yes.
Christina Gio,
Yes.
Howard Savronsky,
Yes.
Catherine Foley Geib,
Yes.
Melvette Hill,
Yes.
Michelle Scott,
Aye.
Betty Ann McDonald, okay, that is the vote. Our team in the back will be doing the official count. So while we do that, we can move on to the next vote, which is for the PRTF recommendation.
The second recommendation, again, it's, the language is noted in your package. I'll just do big picture. The TCB Policy Committee recommends that the Department of Social Services work in collaboration with the Department of Children and Families, Department of Developmental Disabilities, Department of Mental Health and Addiction Services, and we are adding Department of Public Health, to develop a request for proposal to create a 10-bed psychiatric residential treatment facility aimed to serve children, youth age 14 to 21 with intellectual and/or developmental disabilities. There are multiple parts to this recommendation. I won't read through all of it, but big picture, an assessment will be undertaken to determine whether current agency appropriations can support the RFP and ongoing treatment services for the PRTF, which will be billable under Medicaid. If assessment determines that an RFP can be developed, it is strongly recommended that the agency assess the following. And then there are about 4 parts to the following. We will now call a vote for the PRTF recommendation.
Thank you. Claudio Galtieri,
Yes.
Senator Mar,
Yes.
Representative Exum,
Yes.
Jeff Vanderplug,
Yes.
Representative McCarthy Vahey,
McCarthy Vahey votes yes.
Jean Milstein,
Yes.
Michael Powers,
Yes.
Jody Bishop Pullen,
Yes.
Mickey Kramer,
Yes.
Rep Walker,
Yes.
Alice Forster,
Yes.
Sherry Shapiro,
Yes.
Jan Ponson, Melissa Santos, Edith Boyle,
Yes.
Commissioner Hamilton,
Yes.
Michael Moore, or Commissioner Quiros, sorry.
Yes.
Tammy Venega,
Yes.
Lorna Thomas Farquharson,
Yes.
Gerard O'Sullivan, is that a yes? I'm sorry, I didn't hear.
Yes.
Thank you. Kimberly Caranda,
Yes.
Deputy Commissioner Morrissey,
Aye.
Yvonne Paludo,
Yes.
Christina Gio,
Yes.
Howard Savronsky,
Yes.
Catherine Foley Gibb,
Yes.
Melvette Hill,
Yes.
Michelle Scott,
Aye.
and Betty Ann McDonald. Not sure if you joined.
Okay, the team will count the vote. As they are doing that, we did want to give you the last item in the agenda is give the floor to Jill Farrell from the Innovations Institute. Just give an update on the services survey. Jill?
Hi, everybody. I'm Jill Farrell from Innovations Institute. And just a brief update on where we are. Maybe I'll back up briefly. So anyone who's not familiar with the survey, we've been partnering with the services work group who has a charge to understand the behavioral health service landscape for children, youth, and families ages 0 to 18 across the state of Connecticut. The service array really spanning prevention, earlier intervention, through treatment services for mental health, substance use, and developmental disabilities. So we aimed to administer a survey, and in doing that, we started by specifying the sites that deliver services across the state that we would want to get surveys from, as well as what types of services we were looking for to help basically flesh out what the continuum is and what we're trying to identify and what exists and what's missing. So the survey was built around that, the way we defined the continuum, with the goals of allowing folks to indicate what they offer to who and where, in what settings, and also what types of implementation challenges they face, so that we're able at the service level, so we're able to say what exists and what exists but has challenges that might need additional supports from a systemic level to ensure capacity, sustainability, et cetera, and also what doesn't exist based on what's not represented. We administered the survey in July and kept it open through October for folks to respond. A handful were submitted later. And we completed follow-up as well as prepped the initial data that we received. Ultimately, in review, we identified 146 responses that were complete enough to be able to include in the analysis of the data. The analysis, those represent mostly community-based provider sites, although as residential as well, and sites that serve children in clinics, homes, schools, community-based settings, virtual services. It's kind of the good range of types of services and where children and families might receive them. We recognized that we were not capturing the full landscape in terms of service providers in the state. And so concurrently, we started building out a kind of comprehensive site level file that's built from lists provided by DCF, the Connecticut Association of School-Based Health Centers, and other state agencies and organizations that gave us lists that we then crosswalked to identify all the sites where these services are delivered and finding the unique ones across those lists, which was quite a challenge, actually. But we're close to having something that seems like at least based on these sources, the ranges of entities that could have responded to this, such as, to be really concrete, like how many clinics could serve children in the state of Connecticut, and how many surveys did we receive from clinics in general? How many school-based health centers do provide mental health services across the state, and how many surveys do we have for those types of sites? So then, as we're analyzing the data, we can be very concrete or at least contextualize what we have relative to the greater picture within Connecticut, and be mindful of that while interpreting the findings. So we've shared preliminary findings of the data with the services work group. We have since rolled that data into a data visualization platform to help with slicing and dicing it. It's while it's it's not representative of all service sites, the information provided is pretty comprehensive and insightful when you get into specific service buckets such as crisis services, substance use services, prevention services, and gives, I think, as we're looking at it from a geographic lens or at a very specific service lens or intensity level lens, it helps us understand the challenges that service providers are facing when delivering these services and what's potentially at risk and what they face specifically related to wait list capacity and stuff like that, that we're summarizing now. So in terms of our current steps, we're finalizing that analysis. Providers also had an opportunity to write in some open-ended text responses related to unmet service needs and other challenges they're facing regarding service delivery or populations who they have unmet needs. And we're analyzing those to pull out the themes, layering in the element of geography over this so we can look at this from a regional lens and writing up all of these findings so that we can then bring them back to the, I think the next steps will be the chairs and then discussing with them where we should go with this in the next few months to go deeper in certain places and additional data that could help to, or information from focus groups or whatnot that could be useful in fleshing out ultimately what the current gaps are identified in the state and where we want to build capacity and then recommendations for those. I think that's it, unless you'd like additional information.
No, I think that is it. I know that the services work group will continue to receive updates. And I believe, Jill, if you can confirm for me, we are still on target to release this report and the findings, I believe, by May or June. Is that correct?
Yeah, we're in good shape for that.
Yeah, perfect. Okay, so we will be circling back with this committee sometime in June with the results of that survey. In regards to the recommendations, Emily, do you have the results?
Yes, so both recommendations passed unanimously. The disordered eating recommendations passed with 28 yeses, and the PRTF recommendation passed unanimously with 27 yeses.
Okay. All right, so I believe that concludes our meeting. Our next TCB meeting is scheduled for March 4th from 2 to 3:30. Depending on what else we have, we may extend it to 4, but our goal is to 3:30. Any closing remarks from our chairs?
Just thank you so much for your continued support and all the work that we're doing together. And we really appreciate it. This is exciting and another step forward. Thank you.
Agreed, ready to move forward with this as we get into the legislative session. We're going to need everyone's support, so stay tuned for the public hearing and all the outreach to legislators who we need to make sure understand the good work that we've done here.
Amen. Thank you.